Hello. Let's talk about the posterior pituitary gland. The posterior pituitary is called the neurohypophysis, and it's called so because it's derived from brain tissue, neuro, and then hypophysis, essentially referring to the pituitary itself. And two hormones are produced in the posterior pituitary that are not made anywhere else in the body, and those are vasopressin, also known as antidiuretic hormone, and oxytocin, the love hormone. So in this SDL, we talk about a couple of ADH problems. Then we talk about a craniopharyngioma, which is going to be a suprasellar benign tumor that is of pituitary origin. And finally, we cover this disease called hypophysitis, itis meaning inflammation, hypophys just meaning pituitary gland essentially. So the spread here, you're going to get one question from all four of these pathologies and two from one of them. So let's get into it. Now, diabetes insipidus, diabetes, understand, is derived from the Greek word for a siphon. And what a siphon is essentially a simple tool for moving water from one basin to another. And so when this disease was called diabetes by old-time physicians, they were referring to the fact that patients were pissing like waterfalls, like all day long. These patients were just pissing and pissing and pissing. And so diabetes mellitus, well, the mellitus in that one means sweet, and that's because it smells sweet. It tastes sweet. Yes, they used to drink urine to diagnose things. And well, why does it smell and taste sweet? Because there's a ton of glucose in the urine in diabetes mellitus. Now, in diabetes insipidus, insipidus means tasteless, right? So that's in contrast to sweet diabetes, diabetes mellitus. And in diabetes insipidus, you have got basically pure water that you're peeing out. And the reason why you do is because ADH just isn't working on the kidneys. So antidiuretic hormone, let's think about that. What does it do? Well, the opposite of diuresis. What's diuresis? Well, diuresis is peeing. And so if you've got antidiuretic hormone, you're going to be holding on to water and not peeing as much. And in fact, you will produce a very small volume of extremely concentrated urine. Take a good look at this. Absolutely the picture that you need to bring into your mind every single time you ever see ADH anywhere. This is courtesy of Dr. Augustiniak, my physiology professor. Really great material here. Understand that when you've got a lot of ADH, you are producing a tiny, tiny amount of highly concentrated urine. And on the y-axis here, we've got tubular osmolality. And look, it's like 1,200. That's 4 times that of blood whenever you've got maximal ADH secretion. On the flip side of that, when you have no ADH at all, you are producing a very large amount of dilute urine. And without any ADH, urine's got an osmolarity of as low as about 30, which is like 1/10 that of blood. So that's what we're referring to when we're saying that with some sort of ADH resistance or lack of ADH, you're basically peeing out pure water. So that condition is called diabetes insipidus, and it can be because you're either not making ADH in your pituitary or because your kidneys aren't responding to it. And then there's a third variant that's gestational diabetes insipidus, but obviously that patient will be pregnant and you'll understand, you'll connect those dots very quickly. So polyuria is the name given to the symptom of frequent urination, and it's accompanied usually by polydipsia, which means I'm very thirsty. I want to drink a lot of water because I'm peeing so much to replace that fluid that I'm losing. So the differential for polyuria does include all types of diabetes insipidus and mellitus, and that's because, again, the diabetes refers to the polyuria itself. And also on the differential is going to be hypercalcemia, and hypercalcemia enforces polyuria. You pee a lot when you have a lot of calcium because calcium is going to inhibit the NK2C channel in the lumen, the apical membrane of epithelial cells of the thick ascending loop of the kidneys. And so when you block that channel or kind of compete with all those other cations with calcium, if you've got a lot of calcium, well, then that means that you're reabsorbing less ions total, so more water is going to stay inside the lumen of the kidney and make its way out the collecting duct as urine. So hypercalcemia is going to, again, inhibit or compete with cations for that NK2C channel in the loop. And you also got to consider psychogenic causes. There's this, what's it called, psychogenic polydipsia. Some people just like to drink, you know, they feel compulsed to drink, and that's a DSM type of problem, but it does exist. It's out there. I want to make you aware of it. And then finally, there's a handful of drugs. Can't name any off the top of the head, but I'm sure that polyuria is going to be a side effect of a great many drugs. So then the SDL is going to talk about how is ADH synthesized, and this is kind of anatomy, bit of physiology, leading to help you understand the pathology of what's going on here. Because in neurogenic diabetes insipidus, the reason why the patient's peeing so much is because their pituitary gland isn't making a lot of antidiuretic hormone. And so in the absence of ADH, again, you're producing a large amount of dilute urine. So what could cause you to not make enough ADH? And probably the most common answer to that is going to be brain trauma, the most frequent variant of which being just whiplash, car accident. Anytime your head is jolted, you know, that can sever or impinge the stalk of the pituitary, which could cut off and completely sever the axons of what's called magnocellular neurons here, which are very nicely illustrated. They're the green neurons in this image here on the left. So magnocellular neurons have their cell bodies in the hypothalamus, specifically in the supraoptic nuclei and the paraventricular nuclei. And the cell bodies are there, and their axons reach down through the infundibular stalk. The infundibulum is the stalk of the pituitary. So the axons of these neurons travel through the stalk, and then they synapse right next to the hypophyseal veins of the posterior pituitary. And because they synapse so closely to that circulation, that means that when these neurons synthesize ADH and they're ready to spit it out, they put it directly into the bloodstream, and then it very quickly makes its way within a minute or two to the kidneys. So the pituitary gland does have a dual blood supply. You've got your superior hypophyseal artery that's going to lead into your hypophyseal portal and then continue to drain down venously into the anterior pituitary. And then you have your inferior hypophyseal artery, which supplies your posterior pituitary gland, also known as your neurohypophysis. So aside, anytime you hear hypophyseal portal mentioned, what people are really referring to with that is going to be the superior hypophyseal artery derivatives that go on to supply the anterior pituitary, because those vessels are going to intertwine and disperse within the median eminence of the brain, which is right underneath the arcuate nucleus of the hypothalamus. And here is a coronal slice of that. You've got these blood vessels, and you've got neurons in the hypothalamus that are serving to sense the concentration of various solutes and hormones and chemicals in the bloodstream, and then respond accordingly. So if there's any problem whatsoever with the release, production, transportation, and release of ADH into the bloodstream from these magnocellular neurons, well, then you're not going to have enough ADH to be able to hold on to free water. You're going to lose it all in your urine. So that's neurogenic diabetes insipidus. After ADH or vasopressin gets into the bloodstream, it acts on the kidney. It binds V2 receptors, and you know what that's going to do. It's going to run a cyclic AMP inside the cell, and it's going to get aquaporin 2 plastered onto the apical channel so that you can get some water out of the lumen of the kidney back into the body. And it's also going to upregulate UT1. That's a urea transporter, and it's going to increase the concentration of urea in the interstitial renal space, and water is going to follow that urea out through that aquaporin channel. And then once water's in the interstitium, remember that like the interstitium in the kidney is paper thin, you know, I mean, it's tubule, capillary, right next to each other. You know, it's like they practically sleep in the same bed. And so that means that water is going to go from the tubule to the capillary like that, you know, and urea is going to stay in the interstitium, and then it might find its way back into the kidney, into the collecting duct, into the loop, because remember, you can reabsorb urea down in the medullary segments of the loop of Henle. So ADH, aquaporins, free water back into the bloodstream. You don't have ADH, you don't reabsorb water, all the water goes out, diabetes insipidus. Again, if this is happening because your pituitary is not making ADH, we're going to call that neurogenic or hypothalamic diabetes insipidus. Could possibly be due to an autoimmune process in which there's antibodies directed against magnocellular neurons. We've seen antibodies directed against neural tissue before. A good example of that is multiple sclerosis. That's an autoimmune disease, type 4 hypersensitivity. We biopsy many brains affected with neurogenic diabetes insipidus, and we found lymphocytic infiltrates in the pituitary stalk of many of these brains, which is what leads us to believe that there is some sort of antigen autoimmunity going on there. There are some cases of inherited diabetes insipidus due to mutations in the arginine vasopressin, ADH vasopressin hormone gene. That's on chromosome 20. It's inherited in an autosomal dominant manner. I don't think you'll get asked about that. A mass lesion of the pituitary, maybe something is compressing the posterior pituitary or growing down into the stalk. This stalk is a fine, delicate structure, you know, so if you have a suprasellar mass, let's say that it's growing over here, well, or maybe it's growing out the anterior pituitary, you know, we just had a whole SDL on that. So not only is it going to grow up and bump into this optic chiasm and give you a bitemporal hemianopsia, it might also grow into the stalk. And remember, we said that whenever a tumor grows into the stalk, it can cut off the blood flow to the anterior pituitary, which is going to cut off the delivery of dopamine to that anterior pituitary. And we remember that dopamine has an inhibitory effect on the production of prolactin. And so whenever you have some sort of compression of the arteries going down to the anterior pituitary, big symptom of that is lactation, because if you all of a sudden start making a lot of prolactin, that's the first thing that happens. So same concept here. Now apply it to the posterior pituitary, where we've got these, again, axons of magnocellular neurons that are synthesizing ADH and then delivering it down those axons to hold right next to the synapse and release when called upon. If those axons get damaged or compressed by a tumor, craniopharyngioma, which is coming up next, then there's your neurogenic diabetes insipidus. So gestational, you're going to diagnose that, no problem. Nephrogenic, that means that you're making ADH, but it's not working on the kidneys. For some reason, the kidneys have a resistance to antidiuretic hormone. So no binding, no CAMP, no aquaporins, no UT1. And there's two flavors of it, and it can be due to either the receptor for vasopressin, or it can be due to a defect in the aquaporin channel itself, in which you get the rise in CAMP, but you can't mobilize the aquaporin to the basolateral membrane. And a very common cause, more common than the inherited causes of nephrogenic diabetes insipidus, is going to be lithium, which is used to treat manic depression, bipolar disease disorder. Remember, you got two types of bipolar, 1 and 2, and the difference in them is really in the duration of your manic spells, hypomania versus pure full-blown mania. Now, lithium inhibits adenylyl cyclase in the principal cells of the collecting duct, and that AC is necessary to bop up your CAMP and respond to vasopressin. And so if you don't have that CAMP, you don't have your aquaporin 2s, you're not reabsorbing free water. Now, that's nephrogenic and neurogenic, and they don't care if you know that. I mean, they do, but what they really care is, do you know how to differentiate between the two? So how do you differentiate between the two? Well, you're going to deprive the patient of water, and you're going to wait for their urine to get concentrated. But the problem is you don't have any ADH. So you're going to thirst this patient essentially, and their urine osmolarity is going to stay low. So what's that mean? It means it's dilute. That's bad, because when you are thirsty and your blood volume is dropping because you're not drinking at all, you should be concentrating your urine to conserve water, but these patients won't do that. So you're going to see that and you're going to say, okay, this patient's got diabetes insipidus. Is it the brain kind or the kidney kind? So you're going to give them exogenous ADH and see if they can respond to that. And if they do, if their urine osmolarity goes straight up, you know that that means that when you give them ADH, they start concentrating urine. So you know that their brain's not making the ADH and putting it into the bloodstream. But if you give a patient ADH and their urine osmolarity goes from like 90 to 100, it doesn't go jack, you know? So that's how you know, okay, this patient's kidneys aren't picking up this ADH properly that's floating around in the bloodstream. So easy differential. Clinical presentation, urine output exceeding 3 liters a day can get up to 20. Can you imagine that? Again, keep type 1 diabetes on your differential, type 2 diabetes on your differential, especially in kids and young teenagers. You're starting to see type 2 diabetes younger and younger, and then type 1 obviously tends to present in the 6 to 10 or so age bracket. Patients get dehydrated and they do get a hypernatremia because they're losing free water, not bound water. And that hypernatremia, again, is a kind of a contraction hypernatremia, to coin the term. You might also see an encephalopathy due to big bad ion imbalances. We talk a little bit about diabetes insipidus following cranial trauma or possibly post-op if you've got resection of a pituitary tumor or any other hypothalamic mass. SDL mentions a triphasic pattern where you initially are going to pee a lot, but then you're not going to pee at all because you're going to have a little bit of ADH stored up apparently. And so when there's that trauma and you're not making any more ADH, you use up everything that's stored in your neurons. And then when that runs out, then you're back to peeing your pants. Pathophysiology, talked a little bit about this already. Urine is extremely dilute, under 200 milliosmoles per liter. You should be concentrating urine. Concentrated urine means a high osmolarity. Dilute urine means low osmolarity. The urine-specific gravity is going to be really low as well, and that's a good test for diabetes insipidus particularly, because specific gravity is the density of urine compared to water, water being a standard with a specific gravity of 1. And so the lower your urine specific gravity is, the closer it is to pure water. And so a normal specific gravity is in the 1.015 to 1.025 or so range. And so any closer to 1, that means it's really, really watery. We talked about diagnosis. Here is a good scan of the pituitary. Your infundibulum is going to be right here with your optic chiasm right above it. Here's your adenohypophysis and neurohypophysis. There's your infundibular stalk. Got the median eminence and arcuate nucleus of your hypothalamus, which is kind of shaped like that. Then you've got your thalamus above it there. And right here is your optic chiasm. So that's where we're at. Blood is kind of flowing up the brainstem and then down and out. Here is the structure of vasopressin, really small protein. And desmopressin is going to be our treatment for diabetes insipidus. It's just a vasopressin analog. Let's talk about SIADH, syndrome of inappropriate secretion of ADH. So a lot of drugs give you this. We just said that if you don't have any ADH, then you're peeing out a lot of dilute urine. Now, if you've got too much antidiuretic hormone, then you're going to be holding on to all that water that you were peeing out in diabetes insipidus. So this is kind of the polar opposite of diabetes insipidus in a way, you know, figure out how to look at it. Most frequent cause of hyponatremia. How do you get hyponatremia? Well, you hold on to all that free water because ADH is working too well, you know, it's too nice. And so ADH means aquaporins, means water goes back into the blood. And when that happens, volume expansion. So when volume expands and sodium stays the same, the concentration of sodium drops. There's your hyponatremia. Again, a lot of different causes. It can be a paraneoplastic syndrome. Carcinomas of the lung, pancreas, and prostate can give this to you. Our prostate tumor marker is PSA, prostate-specific antigen. Our pancreatic tumor marker is cancer antigen 19-9. And small cell carcinoma of the lung, you're going to really want to know that like the back of your hand, because it presents, especially on imaging, very similarly to squamous carcinomas of the lung. Small cell is the worst lung cancer that you can get. It's very aggressive, poor prognosis. It can give you a handful of paraneoplastics, not just ectopic ADH secretion, but also adrenocorticotropic hormone. That's going to be an ectopic Cushing syndrome. And it can also cause this Lambert-Eaton-like myasthenic crisis, in which it starts producing autoantibodies against voltage-gated calcium channels, which are found on skeletal muscle. And so if it makes those antibodies, the big symptom of that is paralysis. What's it look like? It's a small cell neuroendocrine tumor, small dark blue cells, and it's going to stain with things like neuron-specific enolase, chromogranin, and synaptophysin. Lots of drugs enhance ADH release, many antineoplastics, barbiturates. Those are going to be like phenobarbital, thiopentol, clofibrate, haloperidol, antipsychotic, histamine, isoproterenol. That's going to be a beta-1, beta-2 adrenergic agonist, pretty useful in certain types of heart failure. Opiates, we know those are pain medications, mu-opioid channel blockers. Nicotine, we know that that's a nicotinic acetylcholine receptor agonist. Remember, you got a muscarinic and a nicotinic receptor. Nitrous oxide, NO, that is a, pretty sure that's a anesthetic gas. Phenothiazines, no clue. Thiopentol, back up there, that's a sedative anesthetic. MAOIs, monoamine oxidase inhibitors, we've seen that in Parkinson's so far. Tricyclic antidepressants, we're going to get there soon. There's a ton of drugs that can give you SIADH. I'm remembering as well a couple of anti-seizure drugs. Pretty sure phenytoin can give it to you, and carbamazepine too. And then finally, if anything's really agitating the posterior pituitary in terms of like some other primary brain pathology, meningitis, encephalitis, brain abscess, all these itises that are causing generalized inflammation, that can really inflame the posterior pituitary and cause some hyperactivity in response to the inflammation. What's the clinical presentation? Patients are holding on to water. They've got a high blood volume. They've got a hyponatremia because, again, it's dilute. They're probably not peeing a whole lot. Compensatory increase in ANP, atrial natriuretic peptide, which is made by the heart, hence the atrial. And that's going to try to reduce your blood volume. You only make ANP when you've drank too much and you need to slough off some of that blood. And so, or some of that fluid volume, you know. So that'll get your blood volume down, but that makes the hyponatremia even worse, because the way that ANP works is by telling you it's going to constrict your efferent arteriole and dilate your afferent arteriole, and that's going to send your GFR through the roof. And so when your GFR goes up, sodium excretion goes up, and so that's not going to help your hyponatremia one bit. Vasopressin escape. Now Google it. I'm not remembering what I Googled from it, so I'm not going to waste your time with it. Clinical presentation, patients gain weight, it's water weight. And yo, straight up, have you ever like gotten on the scale and it's like the next day you're like 8 pounds lighter or something, or like 5 pounds, I don't know, something crazy. Maybe you just have a day where you like hit the gym and then you go run and then you don't drink that much. And it's like, whoa, yo, I lost that much weight. And then vice versa, you know, if you go pig out the whole day, eat a lot of sodium, it's like all that weight's water, you know. So water fluctuations can be pretty significant. So if a patient develops this water weight gain as a result of the drug, you'll probably know it very, very immediately. Big bad symptoms include brain edema, ventriculomegaly. Again, that water's got to go somewhere, you know. GI symptoms, anorexia, nausea, vomiting, headaches and blurred vision, lethargy. apathy, disorientation. All these things are secondary to just a whole lot of water, big blood volume. And hyponatremia is really going to contribute as well to the headaches and the disorientation. Hyponatremia is the defining clinical feature. These patients are going to have a hankering for salt, to put it gently. And this should be a pretty obvious diagnosis too, especially when taking a good history. Understand we want to correct this slowly with no more than 6 milliequivalents of sodium per day, because we want to avoid that central pontine myelinolysis that is an iatrogenic cause of brainstem stroke that can happen whenever you give somebody too much sodium too fast, and it'll just pull water straight out of that brainstem into the bloodstream, and it'll dehydrate your brainstem, and that's not good. Because the water going out, myelin really depends on a good ion balance to stay properly inflated, and so without the water goes. It's like you're vacuuming stuff out, and the myelin breaks. That's myelinolysis. Craniopharyngiomas now. This is the most common suprasellar tumor of childhood. Remember that usually brain tumors in kids tend to be infrasellar, and when we say that, we're referring to the sella turcica, which is the Turkish saddle. It's this cup or groove in the sphenoid bone that the pituitary is just sitting in, and it's kind of a plane, a horizontal plane. And so suprasellar, infrasellar tumors in kids tend to be in the cerebellum, way in the back of the brain, and those tend to be, what are we thinking of? I want to say meningiomas, and oh, there's one that's on the tip of my tongue. I'm not thinking of it, but this is in block 3. So adults can get this too, this craniopharyngioma. And when we're talking about a craniopharyngioma, because of where it sits, it's going to usually present with loss of lateral visual fields, and that's called bitemporal hemianopsia. And it might also present with some endocrine abnormalities because it could compress down onto the pituitary gland. Now, it's a benign tumor. You might see calcifications on an x-ray, and again, it's in kids. So bitemporal hemianopsia in a child, this is number 1 on your differential, followed by various adenomas of the anterior pituitary. You've got some beta-catenin mutations, and that's the only thing you need to really remember about it. BRAF V600E, that means the valine at position 600 is replaced with, I think, a glutamic acid. And BRAF is an oncogene that participates in the MAP kinase pathway. So it's a gain of function mutation versus beta-catenin, which is a tumor suppressor gene, loss of function. You should know that beta-catenin is involved in cell-to-cell adhesions. And whenever cells get ripped off from one another, whenever there's damage, beta-catenin normally keeps neighbors held together. And so when you lose your neighbor, that's what happens when you get a cut or something, a cell loses its neighbor. And so when the healthy cell that's still there that didn't get injured, when that happens to it, the beta-catenin that was keeping it glued to its neighbor translocates to the nucleus and says, you need to divide and proliferate to replace the neighbor that you just lost. So that's what beta-catenin does in a nutshell. Back to craniopharyngiomas, we've got a suprasellar benign tumor. And where is it from? Well, it's from Rathke's pouch. It's an epithelial neoplasm. That's important. What's the cell of origin? Odontogenic rests. Where have we seen those? In, I think they were called odontomas. Something like that. But odontoblasts, those are in your mouth. Those are around teeth. And so we've seen odontogenic rests in the oral cavity. And so we understand that Rathke's pouch is a derivative of the oral cavity. It's like the back of your oral cavity is going to pop upwards, and then your hard palate fills itself in from your maxillary bone. And when that bony shelf fills itself in, it kind of pinches off and sequesters this little tiny bit of epithelial tissue right up there next to your brain, and that grows into the anterior pituitary gland. So that's the cell types and tissue. Here's a visual of it that the craniopharyngioma derives from. Let's take a look at some craniopharyngiomas before I say any more words. Here's one right here in the middle. Notice this motor oil appearance I'm outlining in green. We've seen this with, I want to say, Warthin's tumor in the jaw. I think that's the only other place that we've seen that. Maybe meningiomas as well can have a motor oil appearance. There's a brain tumor that can, I recall. Here is your axial CT showing this centrally located mass. And again, that's suprasellar, supratentorial. Pituitary adenoma is the differential, but in a kid, this craniopharyngioma, I would say, is more common. This thing could calcify, so you might catch it on X-ray. I don't know why you'd be X-raying the head. Maybe kid got hit in the head, or CT definitely. Cholesterol crystals in this motor oil-like fluid, and that's all that first aid thinks you need to know about the craniopharyngioma. Here's histology. Wet keratin, wet-ass keratin is the histologic hallmark of the craniopharyngioma. And it kind of looks like keratin pearls, except they're not really pearls, you know, they're more so smushed. Keratin pillows, maybe. Keratin bean bags. Certainly not pearls, though. And you also see a palisading epithelium and a stellate reticulum. We're going to talk about those. I got those outlined in a different picture. Here's your motor oil appearance. That's a very dark tissue. You can tell that that's absolutely abnormal and can get pretty big too. And the motor oil appearance is going to be from this combination of blood and cholesterol kind of mixing together. And why would they mix? Well, you've got some sort of vascular damage, you know, a hemorrhage of some sorts that's created by the rupture of these high pressure cysts. And cysts are a hallmark of epithelial tumors. And so these cells, these epithelial cells just divide, and they're secreting products into a lumen, and then eventually that just becomes cystic and it can get so large that it ruptures. Here's another slice of a craniopharyngioma showing you its location relative to the hypothalamus and to the optic chiasm, and that's where you're going to get all the symptoms from. This image particularly is the adult subtype of the craniopharyngioma. Remember that bimodal distribution. And the adult subtype is way different than the pediatric subtype in that it is not going to show you any calcifications on imaging. It's not going to have cystic spaces, so it's not going to have the motor oil appearance. It's just largely going to be a solid mass presenting with those that loss of visual field. So getting back into the SDL, the calcifying craniopharyngioma is also called the adamantinomatous craniopharyngioma, and that's the pediatric subtype. So what is characteristic about this tumor compared to anything else, but especially to the pituitary adenoma? Cystic spaces, calcifications, motor oil appearance, and then on histology, very characteristic appearance with three components to it. First, you've got this wet keratin that is, they labeled it with W in the middle of this picture here. You've got a palisading basal epithelium. So palisading, what does that mean? It means lots of tall columnar cells stacked next to each other like dominoes. So if we look at what I've outlined here in the green, what we're seeing is a bunch of cells stacked next, just right on each other, like a deck of cards almost. That's palisading to me. Now, stellate reticulum. Well, what's a reticulum? Well, it's a matrix. Well, what's stellate? Well, that means it looks like stars, right? And so when we think, well, what's a star look like? Well, it's got angles to it. I don't know, because when everybody draws a star, they draw it like that. You know, that's what a star looks like. So that's why we call these things stellate, is we call cells stellate when they have these little pointy appearance edges to them. So that's our stellate reticulum, and it's formed by hydropic vacuolization. Man, I love medicine, just these large words that we are privileged to use. So hydropate means there's a lot of water in it, and vacuolization means that the water is kind of confined in bags. And so if you look at it, it just looks like a bunch of clear Ziploc bags filled with water. So that's the appearance of this tumor. Don't think too much about it. You're not going to get to step one, and they're going to be asking a question that's dependent on you knowing the histology of this tumor. You're going to make this diagnosis so easily because they're going to give you something else besides the histology. In adults, you got this papillary subtype. So everything that we just mentioned, you don't see in the adult variant of the tumor. You see an anastomosing fibrovascular stroma. Anastomosing just means making communications between two separate channels. It doesn't have the motor oil, doesn't have the wet keratin, doesn't have the calcifications. Where is it? Suprasellar, tends to be right above the pituitary gland. How does it present? You get a loss of visual field laterally in both eyes. That's bitemporal hemianopsia. You are probably going to see some sort of hydrocephalus, symptoms of hydrocephalus, and maybe ventriculomegaly if you were to take a scan, because the third ventricle is, let's see if I have a good photo of this. Yeah, this one's pretty good. Understand the third ventricle is, I'm going to use green, basically this space right here, you know. This little dip is the bottom of the third ventricle. And so if you've got a tumor right here growing out of some derivative of the anterior pituitary and it's growing upwards like that, well, then it's going to bulge into that third ventricular space. And if it bulges too much, causes too much of an obstruction, that's really bad. Third ventricle, what's the foramen between the third ventricle and the fourth? I think that's the cerebral aqueduct. Let me double check that. Yes, it connects the third to the fourth, and then the fourth ventricle's got the foramen Luschka or Magendie? Anybody want to take a guess? Let's see. Fourth ventricle, is that the foramen of Luschka or Magendie? I'm going to say that's Magendie, and the Luschka's in the third. No, Luschka's in the fourth ventricle and Magendie's in the third. Okay, so anyways, old complex anatomy right there. Back to the craniopharyngioma. Third symptom you might see, hypopituitarism. So you know it's going to be a deficiency of various circulating hormones, most commonly growth hormones. So because this is typically a pediatric tumor, you're going to notice the growth hormone deficiency, but he's just going to stop growing on you. And then secondary to that, FSH, LH, those tend to be, those are gonadotropin releasing hormone downline from that. And you're probably not going to notice that in a child. Adrenocorticotropic hormone, what does that make? Well, it tells the adrenals to make cortisol. And if you were to lose that, then you would go hypotensive and probably feel very fatigued because cortisol is a get up and go type of hormone. And TSH deficiency, that's thyroid stimulating hormone, we'll get the hypothyroidism. CT is imaging of choice. MRI is nice too, but because these things calcify, that's going to likely be in the question stem. Great prognosis, benign tumor, just go in and take it out. And don't mess up. Primary hypophysitis. Well, hypophys, pituitary, itis, inflammation. So it's an inflammatory reaction involving the pituitary. It can be due to a handful of things. Systemic diseases such as autoimmunities, Crohn's, Takayasu disease, that's a large vessel vasculitis, remember. GPA, granulomatosis with polyangiitis, that's pulmonary renal syndrome. Sarcoidosis, that's just systemic fibrosis, essentially. Langerhans cell histiocytosis, don't really know that. Post-infection, viral, bacterial, fungal. A lot of things can give you hypophysitis. You tend to get it in the anterior pituitary more so than the posterior, and we're going to look back and reflect upon the, where was it? It's in the SDL. We're going to reflect upon the vasculature of the pituitary, and we're going to see that the anterior pituitary, again, has a little bit more thorough of a vascular supply. Notice this superior hypophyseal artery here. generates that portal system, and then there's just more blood, period, going into that anterior pituitary. So that's why it's more common. Function of probability right there. Now, what do you see on histopathology? Bunch of lymphocytes. It's an itis. You're going to see immune cells everywhere, which you really would not see in any other setting in the pituitary gland except for this hypophysitis. What kind of T cells are they? CD8 T cells, suggesting some sort of autoimmunity. Maybe in the case of post-infectious, it's a molecular mimicry that's going to get some sort of type 2 hypersensitivity popping off. And then in the case of these other diseases we listed, there are many antigens that we already know of that might be expressed in the pituitary, I suppose. There's a granulomatous variant, giant cell granulomas. Surprise, they're not going to ask you about that. They would probably use hypophysitis as a segue into asking you about some sort of physiology question or hormonal axis question. If they show you the picture and then say, what does this patient have? And you say, thank you. Remember that GH is typically the first thing to go down, followed by FSH-LH, followed by ACTH. Patients are going to have headaches because the pituitary is right there in the middle of your head. Makes sense. If it swells up because inflammation causes edema, so that can cause swelling, maybe that budges a little bit on the optic chiasm, giving you a bitemporal hemianopsia. Large majority of patients show those endocrine dysfunctions. That's probably what they want to ask you about. Old Arbin weaves together his words masterfully here. There is an inexplicable, unique predilection for the corticotrophs and thyrotrophs to be affected by hypophysitis, while the gonadotrophs may be spared. You take a picture of the brain, and it's going to show you diffuse inflammation of the pituitary, as opposed to if you have a tumor, you know, it's going to obviously be on one side or another, or just a big old thing. But if the pituitary is just a little bit swollen in all directions, you call that diffuse. And this theme of diffuse swelling pops up again in the thyroid, where you say, okay, it's swollen all over, maybe you have Graves' disease, versus, oh, you've got one part that's swollen, okay, we're thinking that that is a mass. And empty sella is the final outcome of hypophysitis, and we know that empty sella just means that your pituitary just gets smushed down into the sphenoid and there's not much left, and it's not very nice. So those are our diseases of the posterior pituitary. For now, we didn't talk about oxytocin. Remember, that's also made by the posterior pituitary, but I assume that we're going to cover that quite adequately when we get to the reproductive section of this block. Thanks for listening.